Yeah, applying our approaches in mental health, we first got to remember what a broad area that definition covers. That can cover people who end up in hospital admissions and in acute psychiatry, right the way through to people with depression, other issues, who may sometimes show some kind of hostility. The basic ideas about applying work in mental health is very clear to me. We've had successful programs, particularly actually funny enough overseas in Denmark and Scandinavia, where our training has literally been applied with very subtle changes to mental health services, particularly psychiatric services. Again, the kind of challenges that we face is how people feel comfortable in supporting those individuals who can sometimes, for example, in acute admission areas, be incredibly distressed and incredibly confused. One of the key things about our approach is actually to develop a hands-off policy as much as possible in supporting people in a crisis in mental health. For too long, there have been individual restraint-related deaths, which I know are only a small minority in the field, but one death too many is too much. So our approach to mental health really looks at the entire crisis response. For example, if you're going to reduce restraint in mental health services that are secure services, you've also got to think about seclusion. Wherefore actually reducing restrictions around individual. Obviously, the more you individualise services, the easier it is to actually try an approach such as a low arousal approach. Because again, you're not trying to cater for a mass group set of needs in this kind of area. So when applying our approach in mental health, one of the core features is that often we're dealing with, quite frankly, environments that can be quite poor in quality at times, where we actually have groups of individuals, usually, for example, detained under the Mental Health Act in the UK or in Europe, where there is actually a group-based mentality to actually support and care. When we're looking at dealing with, for example, extreme behaviours, if somebody is in a more individualised service that's their own front door in their own home, then staff can often withdraw much more easily in those settings. Often they can't withdraw in group-based acute psychiatric settings because their main role is to protect other people who are in that situation. So for us, sometimes our approach to mental health in that end of the field is often to provide a consultative approach that's not just about training. It's about thinking about how you support people in that environment. The other thing that I would point out is that a number of individuals live incredibly what they described as chaotic and disjointed lives. I remember working with one adult woman in her 40s who actually, in recovery, was talking very clearly about how, to her words, how crazy she thought she was when she was admitted into hospital. So one of the things that we need to look at quite strongly is that contextual information. And what I would say about mental health, which reflects other areas that I've worked in, is there is a strong voice that's growing and emerging across Europe and services across the world that, again, we must be listening to our consumers. So there is no earthly reason why low arousal approaches and training can't be applied well to mental health. In fact, our information shows that you can reduce restraint, you can reduce restrictive practices, you can reduce those things quite dramatically by teaching people better de-escalation strategies. And if you think about it, the better we are at de-escalating situations, the less we have need for restraint.